femur, we've got a greater and lesser tubercle, just like we had a greater and lesser trochanter in the femur. A lot of muscles attaching to the humerus, just like the femur. Next week, we're going to think in detail about distal humerus, in particular, excuse me, the medial epicondyle and the lateral epicondyle, because I'll say it now, just because, as you know, repetition helps when you're learning anatomy. A lot of flexors that cross the wrist attach to the medial epicondyle, so this is the common flexor attachment site, and a lot of extensors that cross the wrist attach to the lateral epicondyle. So this is a common extensor attachment site. We talked last week about the intertubercular sulcus and 3 muscles attached in the vicinity of that. Pec major, latissimus dorsi, teres major are the 3. Some new things. If you look at posterior humerus, there's a little groove. For the radial nerve. So the radial nerve, right, comes off posterior brachial plexus and travels back here. And what it's going to do is, I'll do this a few times today. At about the lateral epicondyle or slightly before, it'll divide into a deep branch and a superficial branch. So we got a superficial radial nerve and deep radial nerve. And what the deep radial nerve is going to do is pierce a muscle that's called the supinator. I don't know. Like whenever I hear that, I just for some reason I think of Arnold Schwarzenegger, and so I call that the supinator muscle. So that's what the deep radial nerve pierces. And then, folks, and you're going to see this on a couple bodies. Our presenters are going to show it to you next week. The deep radial nerve, after it's pierced the supinator, continues as a nerve that travels right on the interosseous membrane that connects the 2 bones of the forearm, just like there's 2 bones of the leg, and there was an interosseous membrane connecting those. And this is the posterior interosseous nerve. Okay, so radial nerve divides into a deep radial and superficial radial. At about the lateral epicondyle, the deep radial nerve pierces the supinator muscle. And when it exits that muscle, it's now traveling on the interosseous membrane that connects the 2 forearm bones, and it changes its name to posterior interosseous nerve. So, a little bit of contextual anatomy there, while we're thinking about the radial groove on the back of the humerus. So, let's think about some muscles that move the upper limb and that have attachments outside of the scapula. So, like, we actually learned all of these in the 2nd week of this course. So I'm not really going to go into detail again, but you want to kind of remind yourself of the lat. That is an extensor and a medial rotator and an abductor and innervated by thoracodorsal nerve. So like we're coming back to these because these are innervated by branches of the brachial plexus, right? The thoracodorsal nerve is coming off the posterior cord. Trapezius is innervated by cranial nerve 11, so I guess that's not brachial plexus. The rhomboids and levator scap are innervated by dorsal scapular nerve. That nerve coming off C5, off the roots, that's the brachial plexus nerve, right? Okay, so the common theme of these muscles, they can move the upper limb, and they don't have proximal attachments on the scapula. Yeah, it's true. Rhomboids, levator scap, even trapezius do have attachments on the scapula, but their proximal attachment is not, right? Okay. And then we got some muscles off the chest wall, and we've kind of thought about these mostly before, but we'll think about it in more detail later. So here's that trap. And reflect it, you always want to think about muscles in layers. If you reflect it, you can see a set of rhomboids coming off the medial aspect of the scapula. Here's the lat. And here's the lat again, the proximal attachments, including some coming off the iliac crest. And it spirals like this to attach near the intertubercular sulcus of the humerus, and that explains kind of paradoxical action for a muscle coming off the back, medial rotation, adduction, right? In addition to extension. And when we looked at this in the second week, we didn't see the nerve tube initially because it was covered by the muscle, but now we've seen it. And here you can see from a frontal view just how the lat actually spirals up towards the front and attaches near the intertubercular sulcus. So there's your lat. Okay. Look that up in your own time. You've seen rhomboids before. If you didn't see this, look for it on the new cadaver. We have a nice new section where you can see where you can see the dorsal scapular nerve going to the rhomboids. So this is not new. Moving on. Pec major has a clavicular attachment, sternal attachment, and then distally, it also is attached to that intertubercular sulcus. And it has such a large surface area that it's going to be innervated by the lateral pec and the medial pec nerves, which we thought a lot about last week. And that medial pec, before it gets to pec major, it pierces pec minor and innervates it. So medial pectoral nerve hits both of the pectoralis muscles. In this middle picture, you can see how they reflected pec major. Among other things, pec major can adduct the upper limb, flex, at least at the shoulder joint a teeny bit, minor role there, more of an adductor, medially rotate. Pec minor kind of is playing more of a role of just sort of stabilizing the scapula on the thoracic wall. Here's pec minor. And pec minor was one of three muscles attaching to the beak of the scapula. Remember, coracoid is beak. To remind you of the other two, short head of biceps and coracobrachialis, which we'll see this in a second. They made a mistake in this textbook. There's a P here. Subclavius muscle. The subclavius depresses the clavicle. Okay. Serratus anterior, pretty cool muscle coming off most of your ribs, with the exception of 10 through 12, and attaching to the upper medial aspect of the scapula. And so what it's going to do is rotate the scapula. We talked about this, like if you want to abduct to 180 degrees, first 15 is supraspinatus. If you want to get up to 90, that's deltoid. And if you want to get up to 180, that's really serratus anterior in the front, trapezius in the back. And why is that? Because that abduction of the upper limb, it's not just due to the head of the humerus rotating within the shoulder joint. It's actually due to the whole scapula rotating. And if you want to rotate the whole scapula, you need serratus anterior in front and trapezius in the back to do that. So to summarize, you want to abduct upper limb. We're going to start with supraspinatus, then we're going to kick in deltoid, and then we're going to kick in serratus anterior and trapezius. And serratus anterior is interesting in that the nerve to it is coming off C5 to C7 brachial plexus roots, and it is innervating it on the surface. So it's breaking the rule, so that muscle isn't protecting it, right? And therefore, if you're doing a mastectomy to remove a tumor in the breast tissue, or you're going into the axilla because you want to biopsy axillary lymph nodes, and why would you do that? Because breast cancer, if it metastasizes to the axillary lymph nodes first. So those are sentinel nodes, probably the most important lymph nodes to know about in the body because of that relationship. Then the surgeon has to be careful that they don't cut the long thoracic nerve by accident. And if you do, then you get what's called a wing scapula. If you have the patient press their arms against the wall, the side of the damaged thoracic nerve will wing out. The scapula will wing out. We call that wing scapula. I had a student in here like 5 years ago. I had one, and he liked to demonstrate it for us. But he's gone now and practicing. He's practicing PT. Can't rely on him anymore. Shows that. It's just read that in your own time. Okay, so here's a wing scapula cartoon representation. So this would be an individual who on the left has a left long thoracic nerve damage. The mnemonic is C5 to C7, wings to head. That's the mnemonic to remember. What do you see if you damage the long thoracic nerve? Okay. Winged scapula. Normally, serratus anterior helps protract the scapula. And the other thing is also rotate it. Okay. I think I went over. Didn't I go over the rotator cuff muscles last week? Yeah. It's gonna be a short lecture. I think basically we're done. Oh, you guys are like totally skeptical? Yeah. Okay, you tell me then. Let's just review then since we did this. If I were to damage supraspinatus, what kind of weakness would I see? Abduction. If I were to damage infraspinatus, what weakness would I see? External rotation. If I were to damage teres minor, what weakness would I see? External rotation. If I were to damage teres major, what weakness would I see? Medial rotation, abduction, almost similar to the lat. Okay. What nerve innervates supraspinatus and infraspinatus? What nerve innervates teres major?
Lower subscap.
Lower subscap. Does lower subscap innervate anything else?
Subscap.
Okay, cool. You guys got that. What's the only rotator cuff muscle that attaches to the lesser trochanter?
Subscapularis.
Subscapularis. So that means all the other rotator cuff muscles attach to the greater trochanter. Here's teres major, so kind of like the lat, right? It's a little paradoxical. It's coming off the back, the posterior aspect of the body, but it's spiraling around to the front, attached to the humerus, the tubercular sulcus, and so for that reason, it can immediately rotate and adduct the upper limb. It's counterintuitive, right? So this is new information. Can you guys? Well, before I ask you to do this, so here and we've done this on a few bodies. So you want to see this? You could look for it this week, or you could wait till the next week, whatever. But on a few bodies, we bisected supraspinatus, so you can see the suprascapular nerve and artery coming in. Yeah. And do you remember that mnemonic? Army over the bridge, Navy over the bridge. What's the bridge? Superior transverse scapular ligament. Okay. So we got bodies where we reflected supraspinatus, so you can see those guys coming in. Then what those vessels do is they wrap around the spine of the scapula, just like this, and they hit infraspinatus. Same nerve, same artery. You want to see that. And on a number of bodies, we've bisected infraspinatus. You can see that too. Now I want to point your attention to teres minor and teres major. They're parallel to each other, and if you're trying to differentiate them, and it's difficult to do often, the easiest way is to look for the long head of triceps, and the long head of triceps goes over teres major and under minor. And if you do this, can you take 2 fingers right now? All right. Your second and third finger on your left hand, and take your second and third finger on the other hand, and stick them like that. And do you see how I just made 3 holes? This is also what I do when I want you guys to just leave my office or stop talking to me. This I cast an evil spell. And so that's the upper triangular interval. That square thing is the quadrangular space, and that's the lower triangular interval. Upper triangular interval, quadrangular space, lower triangular interval. Check it out. Upper triangular interval, quadrangular space, lower triangular interval. And the reason we teach this is there's stuff that you combine in those 3 windows. So in the upper triangular window, so here's upper triangular window, here's quadrangular space, here's lower triangular window. We got the circumflex scapular artery. To remind you, axillary artery has 3 parts separated by pec minor. First part has 1 artery, superior thoracic artery. The second part has a lateral thoracic artery and a thoracoacromial trunk with 4 branches called cadavers, our dead people. And you saw the Benfield branch previously. And the third part has 3 branches, 2 circumflex humeral, posterior and anterior. And then we had this subscap artery, and that continued as thoracodorsal artery to the lats. But there's a little guy that wrapped around the scapulus, circumflex scapular. That's this. That's what we could find in the upper triangular space. What do we find in the quadrangular space? Posterior circumflex humeral artery traveling with the axillary nerve. Yes! And what did we find in the lower triangular W? Space. Okay, or interval. The radial nerve traveling with profunda brachii artery. So let me just remind you now. After the axillary artery passes teres major, it changes its name to the artery of the arm, which is the brachial artery. And we got a problem, just like we had in the thigh. Do you remember the problem with the thigh? All the blood supplies in the front. We gotta get stuff back here. Okay. So we had a femoral artery, then we had a deep femoral artery. Same thing here. This brachial artery is in the front.
but we got stuff in the back of our arm. So we're gonna send off a profunda. Profound means deep. A profunda brachii artery to the back. And the radial nerve is gonna travel with that. And you can see that relationship if you look in the lower triangular space or interval right there. You separate 2 or 3 heads of triceps and you peek in there. So this little hand-pneumatic upper triangular interval, circumflex scapular artery. Quadrangular space, axillary nerve. Lower triangular interval, radial nerve. Okay? All right. Got it? Okay. So 3 spaces in the scapula. You could look for those this week, or you could wait till next week. Our presenters next week are going to show it to you also. Okay. So you fractured the surgical neck of the humerus. That's a really common way to damage the axillary nerve. The axillary nerve is heading towards the shoulder, right? Sensory to the shoulder region, sensory to the skin of the deltoid, 2 muscles. And another way is you wear, probably more common, you wear crutches for a long time. Thinking about the 2 nerves coming off posterior cord, axillary and radial nerve. You wear crutches for a long time. That's exactly the part of the brachial plexus that you're going to compress. And so there's a phenomenon called Saturday Night Palsy. I don't know if any of you ended up in a Saturday Night Palsy situation after your Halloween party. I don't know if you want to fess up. Did Iscamelia end up in a Saturday Night Palsy situation? This is the Saturday Night Palsy situation. You did too many danger shots. Danger zone shots. I wasn't there to show you what those are, sorry. And you're walking home, and you see a park bench, and you just decide to park yourself there for a bit, and you drape your arm over the back of the bench, and you pass out. And so now the back of the bench is compressing the posterior aspect of the brachial plexus, and you end up with a temporary radial nerve palsy and or axillary nerve palsy. That's less common, unless you're part of a frat, I suppose, or a sorority, than a crutch palsy. But either way, you can get a radial nerve or an axillary nerve compression, right? That's the crutch here. Okay. If the axillary nerve is damaged, you expect weak abduction, among other things. If the radial nerve is damaged, anyone know the classic radial nerve sign? Wrist drop. So all the muscles back here are extensors, basically, and so if you have weak extension across the wrist, wrist drop, weak extension. Okay. So we're starting to think about these danger zones for the nerves of the upper limb. So fracture, surgical neck of the humerus, crutch in the axilla, compressing the posterior cord. All those things can damage axillary nerve or radial nerve. Right? So you can see how if you're wearing a crutch for a while, the posterior cord, the radial nerve and or axillary nerve could be impinged. Okay? And you might see loss of sensation of the shoulder or muscle weakness like I just talked about. Okay? So here's a surgical neck of the humerus fracture on the right, and that could also damage axillary nerve. Okay. We talked about this last week. To me, it's surprising why there's such a rich anastomosis of blood vessels around the scapula. Check it out. Dorsal scapular artery, circumflex scapular, subscapular coming down here. For the scapula, I don't know. These rotator cuff muscles are important. Yeah, they are. But like the heart doesn't have that. Weird. But it's what we see. So this is an anastomotic network. We talked about all this before, so in the interest of time, I'm just going to move on. Let me just point out 2 vessels one last time that are important to know that they travel with nerves. So one, posterior circumflex humeral, traveling with axillary nerve. Two, profunda brachii, traveling with radial nerve. Okay, so, and on the scapula, dorsal scapular nerve, traveling with the artery of the same name, right? Okay. So, dorsal scapular artery, traveling with dorsal scapular nerve. And you can see that on the new body. Okay. I think most of the brachial plexuses that you may have looked at last week probably didn't see dorsal scapular nerve in C5, but you can see it on the new body. Okay. All right. This is that circumflex scapula that's coming up, and that you're going to see in the upper triangular space or interval. Okay, remember, little finger pneumonic, little upper triangular interval, you can see that circumflex scapular artery there. Okay. Here's a specimen where they remove supraspinatus muscle, and you can see that superior transverse scapular ligament, and you can see how suprascap artery goes over it, suprascapular goes under it, so the pneumonic is army over the bridge, maybe on the bridge. Okay? So see how today's a lot of review. So in lab, you're going to be able to focus, if you want, mostly on brachial plexus. Yay! Okay. So, new material, muscles of the arm, so easy. 4 plus, and this is a mistake too, there's a P right here. This is the panconius. Okay. You know, and if Dr. Escamilla, challenges you on that, you can tell him no. Ernst is right. I've seen the latest textbooks. It is now called the panconius. Tell Dr. Escamilla that. He just doesn't believe it. So, first muscle, biceps brachii, 2 heads. One head coming off the coracoid process. That's the short head. And then another head, the long head, coming off the supraglenoid tubercle. Let me remind you, remember, the glenoid fossa is a little supraglenoid tubercle up there, and an infraglenoid tubercle down there, and long head of biceps attaches to the supraglenoid tubercle. What attaches to the infraglenoid tubercle? Long-headed triceps. Okay. And this is key. Biceps attaches to the radial tuberosity. It's not attached to the ulna, and there's only one bone that spins when you pronate and supinate, and that's the radius. And that's what the radial tuberosity is on. And that explains why, we'll do it one more time. Ready? It's a cool demonstration. Put your arm out like you're shaking someone's hand, please. Okay, mid-pronation. Put your other hand on your biceps. Flex, and you did not feel biceps. I didn't feel anything in my biceps, okay? So clearly something's flexing at the elbow. That's not biceps, folks, that's brachialis. Now, supinate, you felt biceps, and now flex, now you definitely feel biceps flexing. So biceps is a supinator, and then a flexor is not just a flexor, and brachialis is just a flexor. So, why can biceps supinate the forearm at the elbow? Because it's attached to the radial tuberosity. And, so important clinically. It happened to me. I was walking to Sac State on my cell phone, I told you this before, Bobby, saw the sign that said, don't go straight ahead because there's a construction site.
all of the students were on the others. They paid attention to the sign. Like, no, man. Shorter, just go straight ahead, dude. I went right through the construction site, talking to my buddy on the phone, tripped over the iron pipe, fractured the head of my radius. All the construction workers were laughing at me, and I deserved it. And guess what I couldn't do for 3 weeks? Open a door, turn a key in the knob. I couldn't supinate because the head of my radius was fractured. And so anyways, got it? So I don't know what the moral of that story is. Pay attention to signs. Don't do what Ernst does. Anyways, there's biceps attaching to radius tuberosity. There is a secondary attachment, and this is called the bicipital aponeurosis, and you can probably see it on the new body, maybe. And it's like this little thin connective tissue, and it's going that way, going medially, and it's kind of important in terms of like covering the nerve and blood vessel traveling down here through the tubular fossa, i.e. brachial artery, median nerve. If you're drawing blood, for example, here, it protects the median cubital vein that you want to draw blood from. It separates that out that you want to draw blood from the deeper brachial artery, right? So if you draw blood here, you're not likely to cause a really bad hemorrhagic blood loss because this aponeurosis is covering brachial artery, it's covering median nerve. You can feel fairly confident that you could draw blood there and not cause neurological damage to the median nerve. So that bicipital aponeurosis is pretty important because of that. Okay, so under biceps we got a muscle that's just a flexor. And why is brachialis only flexing? How come it doesn't also supinate? Because it's attaching to the ulna, and the ulna has nothing to do with pronation and supination. It doesn't spin. It can't help pronate or supinate. So all poor brachialis can do is flex at the elbow. And then we have a really simple muscle to understand. Its name tells you its attachments. It runs from the coracoid process to the humerus coracobrachialis. All of these are innervated by musculocutaneous nerve. Remember, you learned last week, right? Musculocutaneous nerve, if you want to see it, it pierces coracobrachialis. Now, new piece of information. After it's pierced coracobrachialis, it's going to be under biceps and on top of brachialis. So what I want you to do this week, pick up biceps and look under it, and you should see musculocutaneous nerve. Then I want you to do something else. You should see musculocutaneous nerve continue down into the forearm. So after it leaves the arm, it travels down the forearm on the lateral aspect as a cutaneous nerve. So you want to see that, right? So that's why it has the name, musculocutaneous. It's first muscular in the arm, and then when it gets to the forearm, it becomes the lateral cutaneous nerve of the forearm. So it's muscular up here, and it's cutaneous down here. Okay? Easy peasy. Easy muscles to identify. Easy to find the musculocutaneous nerve. You got it, people. Okay. Triceps. Very powerful extensor of the elbow. Theoretically, panconeus. Can extend at the elbow, but I don't know. I wouldn't rely on panconeus for much. I didn't put my money on panconeus. Sorry, panconeus. Yeah, and I don't mean to offend you. Like your whole life, this has like been your favorite muscle. You know what I mean? And you were like excited for years to get into PT school just to learn more about panconeus. I'm sorry to offend you. That's cool. That's your favorite muscle. But triceps is going to play the bigger role here. Okay, just got to break. Someone's got to break the news to you people. All right, find the person who's got to do it. So be it. This is interesting. think I got that. Yeah, put it in here. We all learned, didn't we, when we first took anatomy, that triceps is just innervated by the radial nerve. No, probably most people it's dually innervated. I don't know the percentage, but it's more than 50% of us. It's maybe significantly more than 50%. Dual innervation, radial nerve, axillary nerve. Wow, that's wild. Okay, look it up. This is wrong. Should be a P there. These people. The medial head can be tricky to observe because it's deep to the long and lateral head, and I don't know, I've never seen a lab where you reflect the long or the lateral head of triceps. And, you may or may not see it, whatever. It's there. Okay? You can try and look underneath the long head. Okay. Okay, I'm pretty sure you thought about this in the lower limb, though maybe I didn't emphasize it as much as I should. For the upper limb, you definitely want to do this. You want to start thinking about, what would happen if I had a proximal radial nerve lesion? Like, so for example, Salvador-Niang palsy, or crutch palsy, right? You're compressing the radial nerve in your armpit, in the axillary fossa, right? So you're going to lose function distal to that. It turns out the radial nerve hits Graves' innervation to triceps pretty soon, pretty proximal, right? In other words, it's not innervating triceps down here, it's innervating it up here. So you might have preserved triceps function even with the crutch palsy, but everything else is going to be impacted. See what I'm saying? So you want to start thinking about, because the radial nerve continues all the way down the upper limb, it crosses the wrist, ends up providing sensory innervation in the dorsum of the hand, so you know what I mean? So, for example, I had a friend who cut their wrist on the dorsal surface. I don't know how it happened, but anyways, they lost only sensory function on the top of their hand. All the motor function was intact, right? The lesion was way down here distal, so you want to start thinking about that. What would I see up here? What would I see here? What would I see here, right? Same thing for the median nerve, blah, 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 blah. Okay. So here's that new addition to our understanding of brachial artery. So remember, axillary artery becomes brachial artery after we cross teres major. So up here, this is axillary. Axillary artery is easy to see. You're not going to need me to show to you, but we got a little branch coming off of it, going to the back of the arm, called profunda brachii, and that is going to travel with the radial nerve. So you're going to see that. And if you wanted to see it, one good place to see those two structures is in the lower triangular interval, right there, between the long head and the lateral head of triceps. You see the long head and lateral head of triceps there? Pull them apart gently, look in there, you'll see radial nerve and profunda brachii artery. Okay, so right now. We got some collaterals going down to the elbow, kind of analogous to the knee, where we have these collaterals from above and below that supply blood to the knee joint. We also have vessels from above and below going to the elbow joint, and to make sure that there's still nourishment and blood supply to the elbow joint even during flexion of the elbow. And so you can see these collaterals coming down. from above, these ulnar collaterals. Okay. You see half of the W here, so ulnar, median, and then basically the whole W. The muscular disease is like really artificially, a little bit not as obvious as in some other artistic tradition. Oh, here's that posterior view, and we've kind of separated the long head and the lateral head, so you can really clearly see the stuff that we see in the lower triangular interval, which is radial nerve and profunda brachiae artery, and they're traveling in the radial groove. So here. Okay. This is the upper triangular interval where we would see the circumflex scapular artery, and this is the quadrangular space where we would expect to see posterior circumflex humeral artery and axillary nerve. So this is another, pick of the three intervals at the back of the scapula. Okay. So I mean, I told you really not a ton of new information today, people. So it's mostly this is like a breather week. So again, I'm encouraging you this week really just to hardcore review brachial plexus. Okay? That's the toughest stuff in this unit. Now, imagine we had a fracture a little bit lower in the humerus. We previously talked about a fracture up here, surgical neck of the humerus where we damage axillary nerve. Okay. Now imagine instead we had a fracture. This is a really common fracture where the mid-humerus is fractured. So this is a mid-humeral fracture. What we often see is the radial nerve traveling around the back of the humerus, right? In that radial groove is damaged. So mid-humeral fracture, the radial nerve is at risk, and one of the classic signs you see is wrist drop, okay? Wrist drop. Weak extension. If you can't extend the muscles of the wrist, your wrist is going to drop, okay? Okay. If we go even further down the humerus, now the median nerve is at risk for damage if we have a fracture at distal humerus. So if you have a fracture near the condyles of the humerus, see the condyles? Or the epicondyles, okay? Right up here, distal humerus. The median nerve is at risk. This is called a supracondylar fracture, okay? And let's think about what you might see. So, the median nerve hasn't done anything to the arm. So if you fracture distal humerus, you're going to lose potentially all median nerve function because it hasn't done anything yet. And so like, if you're damaging the median nerve here, and it hasn't done anything up here, that means everything it's going to do is below the lesion, so everything is going to be affected. So what does the median nerve do? And I'm kind of jumping the gun, but we need to start thinking about it. It's innervating in almost every muscle in the anterior forearm except for two. And all these muscles are basically flexing at the wrist. There's also a pronator. So you're going to have weak pronation and actually loss of pronation because radial nerve doesn't innervate pronators. And really drastically reduced flexion and massive impact in the hand, including inability to oppose the thumb, which is a devastating injury. Okay? Devastating injury. Median nerve, you don't want damage. And
So one of the classic signs, so again, we talked about wrist drop if you damage radial nerve. One of the classic median nerve signs is called the hand of benediction. Right? And if you this is also a greeting that my PT students use to greet. Now you got a whole slew. You can take omohyoid, you can do this, you're worried about demons, and benediction. Okay, so let me explain what's going on here. Okay, and jumping the gun a little bit. Can I erase? Not like you can read my writing. Okay. So, and okay, so wow. So nice word. Flexion digitorum superficialis goes to the medial phalanx. You learned about that. And its tendon bifurcates to allow flexion digitorum profundus to go further out. We saw this in the foot. This is a funny hand, but okay. Anyways, okay. Let's say that's the thumb. So something's going on here. Okay. So profundus, flexor digitorum profundus goes all the way out here. That means, and by the way, a branch of median nerve innervates that. Okay. That means the only muscle in the hand that's crossing the distal interphalangeal joint is flexor digitorum profundus. So if you want to make a complete fist, you need intact flexor digitorum profundus. Got it? Yeah, you can make a partial fist with superficialis and some other flexors, but you want to get that going on out there. Flexion of the distal interphalangeal joint. You need profundus, and for profundus to work, you need the median nerve. But actually, two nerves innervate profundus. So this pinky side of profundus is the ulnar nerve, and this thumb side of profundus is a branch of the median nerve. Okay? Right. So now, you got a patient with a median nerve lesion. Maybe it's because of a supracondylar fracture. I don't know what. And you ask him to make a fist. You ask him to make a fist. Assuming their ulnar nerve is intact, 5 and 4 are going to be able to make a fist. But you see what's happening to my 2 and 3? I can't make a complete fist over here because this part of profundus isn't getting innervation. Are you following me? This part is, so I can make a fist over here. 5 and 4 are fisting, but 2 and 3 aren't. And so I end up with this hand shape that's called the hand of benediction. This is not, there are examples, and we'll learn some, of abnormal postures that the body gets twisted into following a nerve injury, where you're not trying to do anything, that posture just starts to happen, right? Unopposed action of muscles that haven't been affected by the injury. But this is different. What we're asking the patient to do here is make a fist, and this is the fist that results. See the problem? So this is where the problem is, 2 and 3. How come these can't flex? Because median nerve is no longer innervating flexor digitorum profundus. Okay? And a benediction. So now let's now go on a little journey. PJ, don't do that again. So you may have noticed, I'm still wondering about this, trying to figure it out. Maybe the simple thing would just be to ask ChatGPT. You guys can do that. So this is a religious image from the Christian religion of a religious figure holding their hand up, and it sure looks like the hand of benediction does. Well, that is the hand of benediction in the Christian religion. We just apply that term for this neurological disorder. So here's the thing: like, you ever have this happen to you, where before you learned a new word, it's like you never noticed it when you were reading. Well, that makes sense because you didn't know it. But after you learn it, it's everywhere, man. Like maybe the word is donut, and you're thinking, no one ever uses that. No, it's all. I just saw donut in the textbook. You know what I mean? Let's see if that's the case with the hand of benediction. So this is Notre Dame Cathedral in Paris. I took this photo, I don't know, probably 10 years ago. There it is. hand benediction. This is in the front of the Notre Dame Cathedral. There's Jesus with the hand of benediction. This is also Notre Dame, and this is, I don't know who that is, but they got a hand of benediction going on. That's a saint probably at the portal to Notre Dame. This is a sculpture of a monk. I don't know where this is, but they're doing a hand of benediction. Everywhere, people. This is some crazed anatomist in the Louvre doing a hand of benediction in front of Jesus doing a hand of benediction, and some other dude doing a hand of benediction. This is a crazed anatomist in front doing a hand of benediction in front of another famous photo in the Louvre. I don't know who the artist is. There's another one, in case you needed more proof. These are some of my former PT students doing the hand of benediction in front of the sculpture doing the hand of benediction. I think actually they were in Paris. They were in the Louvre. This is them again in front of the same sculpture, in case you didn't catch that. I had to update it this year. No, this is them again. That's cool. Look, that's actually just the hand. They're like, we don't even have the body. And then, okay, there they are. So this is this year. I don't know where this was, maybe Paris. There it is again. And then there's another one. And sorry, I went overboard. Yeah. I zoomed in. There it is again. Oh, this is a famous Leonardo da Vinci painting, the Annunciation. And this angel is doing the hand of benediction, and that's, I think, Mary. And this is a close-up, Leonardo's. And then this is the last one. This is cool. And there's two people doing it. I know. So I don't know. Like, I wondered, like, first of all, where, I don't know if any of you know, like, where does this? I've just always been wondering, what's the origin of this Christian imagery? Like, some people, I've looked into it a little bit. Some people think like, if you just have 3 fingers up, maybe it represents the Trinity, you know, in Christianity. But some people have wondered if like an early pope or something actually had a median nerve lesion. So when they were blessing people, you know, they had a hand of benediction going on. I don't know the answer. I'm not sure about the origin of that symbol. Maybe ChatGPT can answer it for us. Oh God, there's another one. Keeps going. Okay, we're done. So here's another thing that this is kind of interesting. This is another median nerve sign. Like if you think about it, you want to make an A-OK sign. Everything's okay. Think about what you have to do with the second finger. I have to flex, among other places, at the distal anaphalangeal joint, but I just told you, to flex at the distal anaphalangeal joint, finger 2, I need an intact flexor digitorum profundus innervated by median nerve. But if the median nerve is weak, I won't be able to have a whole A-OK sign. I'll have a flattened A-OK sign. I'll have a flattened A-OK sign. So that's another thing you could see. And we'll add to it, you know, these other signs. Those aren't exhaustive. Let's take a break.